Then we need to control the pain or abnormal sensation, which has been mainly due to some kind of chemotherapy or some kind of nerve damage due to radiotherapy, or maybe swelling or edema, or maybe how we need to improve the quality of life. So we need to work in these particular 6 principles, and it's not about modality. It is not about the maybe manual therapy. It is the way of approach that what we are giving to our clients, and we need to give the best approaches to our client, which is more efficient and which is evidence based. Let's move that. Before we go ahead, we need to ask our clients that the type of cancer, which part has been affected, what kind of surgery or what kind of management she has been undergone, what are the pre-fitness stage of that client, what the pre-rehabilitation education was given, what is the social scenario of a client, how many days she has been in the hospital, has she given the drain or not, if she has given the drain, how early the drain was removed, because again the arm movement and the neck movement and the pain also been related with the drain which was been inserted after the surgery. So all these things needs to be discussed, and we always call about pre-rehabilitation. So we need to work as a disciplinary team, and we need to work close to the surgeon, maybe the nursing team, maybe the hospital manager, maybe the counselor, maybe something nutritional professional. So we need to work as a team and discuss the things before person going for the surgery or the treatment. So mainly, if we see, these are the main 6 impairment what we see with the cancer clients. Basically, we are dealing with physical and neurological impairment. We are also dealing with the surgical impairment. So our main goal is to minimize the surgical complication which has been impacted on the clients. Of course, if the client is not mobilized early, or if the client is not able to get a good rehab, that will affect the cognition and the behavior in side of the client. And at the last, cosmetological impairment. This is something which is not being looked after in a developing world, but if you really go dig into it and talk with the client, this is something which very much frustrating personally with me, because no doctor or no rehab professional talk with the client. They think that maybe surgeon think that my work is to do the surgery, so I'm just get off with the surgery. And our own professional, they think that my work is to just get the shoulder movement and I'm done. But if you really see, the client is not happy with other part of the life also. So you need to deal and discuss with the client and give what best you can do with the same. So maybe you can suggest with some kind of prosthesis, or maybe what best we can do it by giving some kind of accessories, underwears, or now what are the way out for the same. So discuss with the client is the first motto as a rehab professional. What are the common side effects what we see generally is like maybe scarring, or maybe loss of movement, maybe neck pain, maybe some kind of lymphedema, maybe unable to move the arm, or maybe muscle weakness, or maybe nerve pain, and also phantom pain. If you are a client on a hormonal therapy, maybe she may get a weight gain, and if maybe client has got some kind of inflammation or infection, and if she has been administered something like corticosteroid, that can also produce weight gain and the muscle weakness. So you need to look after the client as a whole and see that what best we can do it on a rehabilitation side. Almost 62% of normal breast cancer population have at least one impairment. So you can see that what is the importance of rehabilitation in breast cancer. But I feel very sad when it comes to developing country, it's not more seriously aware about. Even if you see online nowadays, people are just more advertising on screening and more about surgery, and breast cancer surgeon can talk about surgery other part, but they forget about rehabilitation. So rehabilitation is very much important, and you can see that almost 27% also suffers impairment, about 2 to 4 numbers within 6 years. So just imagine if we have a pain in our hand or in our leg for a day or two, how we think. And the same particular person having undergone surgery, and she may be feeling the same particular amendment for 6 years. So it's a long time and we need to deal with it. And we need to think in a profound way that what is the efficient way to deal with. The commonest is the shoulder movement restriction, upper limb edema, or maybe something like lymphedema, and then maybe upper leg ache, or maybe weakness, or maybe scar tissue around axilla. So different type of surgery gives a different type of complication generally, but most of the surgery can give you some kind of common problems and some kind of management like chemotherapy, which is, and if you administer more of neurotoxic chemotherapy drugs, so that may produce more abnormal sensation to the client. So we need to understand that also which particular drug has been administered to the client. If you see about that, what kind of pain generate and what are the causes of pain in breast cancer. So mainly it is from musculoskeletal, maybe something like a soft tissue around the breast which has been removed, or something like a bone marrow related because of radiotherapy. It has been affected the bone marrow and that causes the bone pain, or something like a phantom pain. Phantom pain is very, very much common with the clients, and almost around 20 to 40% of breast cancer operated clients, they have this particular problem, but they never try to express themselves. And phantom pain, particularly when you talk with the client, they describe that they have a heaviness of the brain, though the mastectomy has done and the breast was removed. They feel that that particular side is very heavy. I feel very itchy. I feel something like a nipple around that breast, or is just milk is coming out, or my duct is very much filled with the milk. So that kind of expression they express with you when they have a phantom pain. And it is very difficult to differentiate this particular kind of pain, but once you are more interacted with the client, once you are more agile with the client about, and if you are more interested to know the problems, then and then you can able to differentiate. Until you cannot able to differentiate, you cannot manage it well. So just try to differentiate these 4 different type of pain and try to manage it in the way what we talk about in the further slides. Now we talk about a few syndromes which are much common with the breast cancer clients. So firstly, now we can talk about post-mastectomy pain syndrome. It is very much common with most of the clients, and it is most commonest if it is lumpectomy, radiation, and chemotherapy has been administered. So almost 33% of the clients have undergone that particular management are feeling this kind of pain. In this pain, they feel something like burning sensation. They can feel the whole part of that particular side is painful. They can see something like a nerve is passing under my breast is aching, or they can feel something like my hand is too heavy, or it has been swelled. And the most commonest site of pain they may experience it is arm or axilla. So this is something very commonest what we deal on a daily basis with our clients, and we need to understand this particular factor also, that which part has been more affected. So, and then we need to correlate with the pre and post surgery, and then we need to manage it better. Other is called axillary wave syndrome. So there is a formation of node happens around the axilla or the armpit, and that produce a rod-like structure and painful. And most of the time, the shoulder movement restriction has been happened because of that. Because if you have a node around this can be more furious to move your shoulder above head. Even you cannot move the shoulder above 90 degree. And this is more because happened because of the contracture of the soft tissue. There is involvement of the nerve and also the involvement of lymphatic system. So this is most commonest with mastectomy clients, or maybe something like a radical mastectomy client. And that's why early mobility and early shoulder mobilization is quite important in breast cancer survivals. Other is most common is called as a hand-foot syndrome. Our fingers, our distal part of our body is basically having end arteries. So they don't have a correlation with other arteries. So that's why it's called as the end arteries. So if you see when there is a administration of chemotherapy, that particular drugs produce that anti-artery to swell or maybe some kind of inflammatory changes in the same. So that produces changes in the body or that particular part, and person can feel like it's heavily burning, or that's a redness around that part, or there is a tight skin. So it's kind of autonomic changes also and bit of motor changes altogether. And most profoundly they find like sensory issues with burning, tingling sensation. At a later stage they can also found ulcers and sores around the skin. Most chemotherapy induced neuropathies are basically happen to by the drugs given after breast cancer, and most of the breast cancer survival are either going for surgery and chemotherapy, or either going for surgery, chemo and radiotherapy. So it is not only the one particular management strategy which is enough for them, because there is an involvement of surrounding tissue also. And when there is a particular screening process is there, if I give an example of Belgium, almost like around 11% of the women, they have a chance of getting breast cancer. So the screening process is quite profound. So they detect the cancer in very early stages, so they will not reach to the stage where they need multiple type of management strategy. So they are dealing with only one type of management strategy. But when we are talking about the developing world where we have a low screening potentials, we are more profoundly seeing cases when it is in the stage 2 or 3 or 4 maybe. So with that particular client, they are needs to follow the multiple management strategies, either surgery, either chemotherapy, either hormonal, or either radiation therapy. So 30 to 40% of the client has been treated with chemotherapy, they get neuropathies. The most common side effect of chemotherapy is nausea, vomiting, diarrhea, peripheral neuropathy, hand-foot syndrome, and mucositis. So most of them, they have this 5 type of implication if they have been given chemotherapy. Now these are the few particular grading of neuropathies. If you see like grade 1, 2, 3, and like maybe sensory, motor, and like autonomic. So in the like grade 1, they are mainly affected of like on and off pain. Grade 2, they are mainly around instrumental ADAs are affected, then the ADS, and then the life-threatening situation. So this is something where it is well documented. If you are doing a documented research or something, you need to grade the same to the clients, and which can also give the profound feedback or the improvement, which also gives a positive outcome. And if you see like a few other drugs which are more prevalent to get the sensory or motor involvement. So if you see the most chronic toxicity drugs are oxaliplatin, which is most commonest used with the chemotherapy of breast cancer, and that's why they give a bit of more of sensory one. So now these are the alkaloid and Texas are the main 2 group of drugs which has been more administered for the breast cancer, and they are more prevalent for motor and sensory involvement also. Now let's talk about lymphatic system. Almost 60% of breast cancer clients, they get lymphedema within 6 years, from 6 months to 6 years of the span. So why they generally get lymphedema? So most of the time the cancerous cells has been transferred from the lymphatic channels of the system. And this lymphatic system, we generally in a layman term call as a drainage system. So that drains the whole dirty or the impurent processes of the fluid, which has been drained from the lymphatic system. And the cancerous cells has been mainly transformed from this particular system, and that then it has been metastasis to other part of the body. So now that's why lymphatic system is very much important while understanding the breast cancer. Everyone know about that. What is breast cancer? What are the type of breast cancer? Why it has been involved? Lymph node, lymph channels, which are the major lymph nodes, cervical, brachial. So as a rehab professional, we know profoundly about that particular things, and we should know and manage it better if we have a basics clear. So if you see like sentinel lymph nodes, or maybe something like some particular surgery are more prevalent to get lymphedema. So if you see like fewer than 5% of women who had sentinel node biopsy have a lymphedema. So this is more advanced procedure, and which can reduce the chances of getting complications. So only 5% of women that go undergo sentinel node biopsy have got lymphedema, while if you see other people have 4 times more higher chances of getting lymphedema if they are just having lumpectomy or other part or other type of surgery. So advancement of management, it is again quite important, and that also reduce complications, and it will also impact that how we need to manage rehabilitation also. Let's just see briefly about the stages of rehab. There are 4 stages, 1, 2, 3, 4. In stage 1, there is a bit of fluid collection, but if you get the limb elevated, that has been reduced. In stage 2, the swelling has not been reduced well, and there is a pitting of it. Stage 3, there is a pitting and fibrosis, and stage 4, there is a skin changes, also some kind of fibrosis, overgrowth, and some kind of inflammatory changes around that particular part. So we need to manage it better from the stage 1, so that we are not developing to stage 2 and 3 and 4. Now we need to move. Okay, anyone has got any question? They can raise the question in between if you want. Now we are moving to stage 2, which is more about functional rehabilitation. Just let me know if I go very fast, because we need to talk much more about the same. So I'm going fast. If you feel it is fast, just let me know in between. Let's go from the functional rehab. So when we talk about rehabilitation, if I be very much frank with you, all my friend, when I has been working in like Africa, firstly, physiotherapy or rehabilitation, the client, they just have an eye of massage. So like whenever we need to talk about physiotherapy, or whenever I go to talk about physiotherapy, they think that you are just doing massage. So first of all, in our profession itself and around our surrounding or the community, we need to spread the awareness that what is rehabilitation. Once they know about rehabilitation, we can talk more about functional rehabilitation. So functional rehabilitation, it is more about restoration program that is designed to provide comprehensive treatment, and it is more focused. If we talk about like a functional rehab in like stroke rehabilitation, so we are more focusing that how that particular stroke survivor need to reach the office by his or her own, or maybe if his work is to do some kind of labor job, how he or she will now more profoundly do his or her job more profoundly, and that's our role, and that's called as a functional rehab. So we need to work and make the person more fit to do the work in his or her environment more efficiently. So that called as the functional rehab. In a contrast to traditional therapy, it is more focused to the goal-oriented approach. So we need to fix the goal, and we need to move ahead with the particular goal that we need to administer. That if as an example, if maybe a breast cancer survivor is having a problem of maybe like reaching on the top of the kitchen maybe drawer, so we need to work on that particular manner that she can able to take out the box from that particular drawer. So we need to work like a goal oriented approach, so that more focused approach, and that will make the client more efficient to go back to the precancerous stage. The most frequent difficulties are basically, it is more about physical and the neurological problems, and we need to get documented with FIM. Different scoring system are there, sweat system are there, maybe We can check the balance by Borg scale. We can check like communication with a different other scale, uh, which has been more valid. We can also check with like cognition and behavior with the like CBT scales. So all the scales we need to get documented before we start our rehabilitation. So we need to work again these principles of like functional rehab. So first aim is to prevent complications. So in breast cancer, we need to prevent contracture. We need to prevent something like an infection. We need to prevent deep vein thrombosis. So we first need to start with the prevention strategy and maintaining the muscles and the bone integrity while the patient is still in the hospital, or we need to educate the client before she or he may be going for the surgery. Secondly, we need to work about flexibility. It is not always about shoulder flexibility. We need to work for the neck also. We also need to work for the thoracic and the chest, because that has been more affected also. And because of the fear of pain, neck and upper thoracic region had been more compromised in terms of flexibility. So we also need to work on the same. Then it comes to ADL. Maybe after a week or so, maybe a client has been gone back to the home and there is no one at the home to help. So now she needs to work, or now she needs to water the vessel, she needs to cook for the children. So all the things we need to administer, we need to ask for the client, what are the social responsibility, what are the social status, and then we need to plan it out the way that once she goes home, she is better to perform her duties in a way which is not compromising the social lifestyle. Then comes to the strength and endurance, then the agility and the quality of life. So these are the main things which we need to work on as a rehab professional. Let's start with the more complications. So like mastectomy clients, they have a more temporary swelling on the breast tenderness, shoulder and neck pain, hardness around the scar tissue, wound infection, and lymphedema, or maybe phantom breast pain. Chemotherapy is more about infection, maybe ulcers, maybe sensory issue, maybe some kind of sleep disturbance, maybe nausea, vomiting, as we looked about. Hormonal therapy has got different problems like dryness around genitals, maybe something like a blood clots, other kind of osteoporosis, which is also secondary osteoporosis due to the hormonal therapy of estrogen and progesterone. The body hormonally compromised, and that can produce secondary osteoporosis. So they have higher chances of getting fractures, and almost 70% of the spinal fractures after breast cancers had never been diagnosed. So once you are treating any low back pain clients, and if they have been undergone with the breast cancer management treatment, also keep in mind that 70% of the breast cancer survivors having back pain, they have underlying fractures in the spine. Both is like radiation, lung tissue, or maybe heart damage, or some kind of secondary cancers, and skin. The skin issues are the most prevalent with the radiation. So most of the clients, they complain that my skin has been stretched out. I am not able to move my neck well. I am not able to move my mouth well. So many of the time you need to work on the TMJ joint also. Because of the breast issue, they will protectively, they have a fear of pain. So they just try to uphold the jaw and the neck movement, which can also produce the pain and stiffness around TMJ and the neck. So these are the 4 most commonest complications. Okay, now as we talk about, we need to work as evidence-based practice. These are the main evidence-based rehabilitation therapy that we need to work on. Yes, few of the manipulation techniques, soft tissues, myofascial release, all that are no evidence-based, and there is not much or limited data available. So we should not encourage to implement such a strategies in our management of the treatment. So in mainly exercise and physical thing, it is more about active therapies. Again, active therapies are better than the passive ones. Even with the non-breast cancer clients, active therapies are better, and it is proven. So if you are going to do, limit your passive therapies and try to motivate the clients to do the active therapies. Even you can educate the client and try to get adherence. So like we have so many other applications, so many other modalities to adhere to the therapy with the clients, maybe some kind of mobile application, maybe like a video calling, maybe like a WhatsApp chat, maybe something like a Zoom call. So many things are available nowadays to let the patient adhere to the active therapies than the passive one. There are a few data available which works on a complementary and alternative medicine, which can also reduce nausea and vomiting and also anxiety. Even like breathing exercise can also reduce anxiety in the breast cancer clients. Then your lymphedema, we will talk more about lymphedema but when we go further, and the psychosocial interventions. So these are the main evidence-based therapies what we are mainly need to focusing on. Let's start that. How would I always tell my colleagues that we need to think about keeping our leg in our client's shoes so that we can feel that what the patient or what the client is generally feels about. So many times calling our client patient is not ethical. In like developer, they can see if you tell them as a patient. So we need to tell or call as a client. So we need to feel them that how they gonna feel it once they have undergone with the breast cancer or the surgery or the chemotherapy. Said what they feel, how they feel, what they should not do, what they should do, how they need to do it, what is the recovery time, what they need to do after the surgery, what is the pre-rehabilitation talk. So I'm just giving a brief that what in my experience I got a regular question from the clients and which we need to work efficiently to give them the right answers. So if you think about like a mornings, they can feel something like can I take bath once I go home? Can I brush my teeth? Can I bend forward? Can I bend backwards? Can I sleep on the side? Can I lift weight? What should I eat? So all these answers you need to have it. Just understand our clients, they understand emotional stories and emotional uh, perception better than the researches. So do not try to give the data to the clients that, okay, this particular data has been published in this journal, so you need to do like this. So the clients are not understanding that particular data or that particular prevalence or incidences. They better understand emotional stories and emotional perceptions. So we need to perceive ourselves in their side and we need to prepare ourselves to answer this question. So if I give from this side, yes, if the client has been home after 5 days of the surgery and if she has not been drained or there is no suture or no dressing, they can have a bath. They can brush the teeth always, even if in the hospital, they can bend forward. If there is no reconstruction surgery has been done for the breast, they can bend forward. They can sleep on the side, maybe after 10 or 15 days. They should not lift more than 5 pounds up to around 1 month and maybe around 10 pounds after 2 months. There is a bit of limitations also if they have been undergone with some kind of other reconstructive surgery. And what should I eat? So they need to again contact with the nutritional professional who can guide them what they just need. Then like other question like, can I go for a walk? Yes, of course they can go for a walk. Can I start my walk? You can minimize your working potential, or maybe you can just try to work from home for an hour or two, and then you can start to pace yourself and go ahead. Can I sit for long? No. In the beginning, if you can sit, let your arm hang around, that may produce a bit of lymphedema or swelling. So we are more advisable to keep your hand more supported or on the bed. Can I go for holiday? How? Can I work in the kitchen? What should I dress or not? This is the most commonest question which we need to intervene when we answer. What should I dress? Because there is an implication cosmetological purpose and the wearing the clothes, because there is a limitation of sublunar mobility and there is a more limitation of neck movements also. So you need to understand the main thing that what, sorry. Can you guys able to see? Is my internet is okay? Jen?
Yeah, it's okay. It is okay.
It's okay. Sorry.
Yeah, it was breaking a few minutes ago, but it's okay now.
Yeah, it's okay now. Okay. Right. Let's work more about our daily routine. So now, can I go for shopping or not? So all these questions, we need to address them because it is something which is most commonest, which I found dealing with breast cancer clients. And that's what we need to prepare, or we need to have been more knowledgeful to answer them. I hope that your client must be having some other questions or some other kind of difficulties which we need to address also. And different locations and a different kind of clients have a different kind of a question to address. So maybe you can also try to routinely note down the questions and feel about it and just try to address the same. For a functional rehab, which is divided into 3 stages, many organizations or many particular support group, they deal with other kind of timelines, but over here we can see about 0 to 2, 2 to 12, and 12 to 24. So from 0 to 2, it is more about education, positioning, breathing exercise, general mobility, hygiene, and do and don'ts. And like once we move forward, then we more talk about ADL, SODER, more flexibility, strength, and endurance. And at the last, which is more about goal oriented and management of chronic condition like lymphedema or some other kind of preventive management, which is more prevalent to the breast cancer clients. So every particular stage, we need to think about ACE principle. We need to alert ourselves. We need to teach our client about red flag and yellow flags, when they need to see the doctor, when they need to talk to the therapist, what are the ways that we need to document ourselves. There is a different documented procedure papers available online even, if you see, like, and how we need to manage it emotionally and how we need to make our clients more analyzed by pacing themselves. So make understand pacing principle and also educate the client about the same, because pacing is very much important, because they get fatigue very soon and they will complain about soreness or pain later on, and that it will take some time to again get back to the normal stage. So pacing is very important, and you need to make the client at the same time more analyze that that particular client is not more tiresome. So you need to deal with energy saving or energy consumption saving techniques also, that everyone has a different way of understanding the same, so that you can manage it better. Now let's talk about pre-rehabilitation. So before the surgery also, we need to talk more about that what are the tests needs to be done, pre-assessment of the clinic. We need to work as a team. We need to work as a team with the surgeon, anesthesiologist, physiotherapist, maybe hospital manager, that how many days she will be in the hospital, what is the procedure needs to be done, what are the tissues that we're gonna remove it, what will be the procedure or the surgical implication, what will be the complication, how physiotherapist or rehab professional gonna again attend the or address the same particular problem, what are the things, and the timeline of home or maybe like community services if it is available. So when we talk about community services, it is more profoundly done in developed world. We will talk about I call as a beauty principle, which has been studied in Canada for the community rehab, and it is very much evidence based, and we'll talk more. So education of the client is very much important in the beginning. So we need to talk more about everything what we have talked about till now. So these things is gives an eye to the client that what would be my stage of life when I pass 1 week, 2 week, or 3 week of the surgery. Let's move from the 0 to 2 weeks. So mainly plan out yourself. We need to focus on shoulder mobility, neck mobility. We need to prevent complications. So we need to work about the positioning of the limb. We need to work about the early mobility. we need to work about the ADLs and the ambulatory, mainly ambulations, that how often the client needs to go off the bed, how she needs to transfer. So we need to also teach the transferring activity. Also, we need to work as a dressing consultant, because so many times having the drain around the breast area, it will not be comfortable to dress the client by herself. So we need to teach that how to modify the dressing, and how that, if it is not a button, okay, we can just ask to put something like a male and female back row, so it is more easy to remove by herself. So all this thing needs to be talked about. It's mainly about position, ambulation, prevention of DVT, mobility of shoulder and neck movement, maintaining the lung volumes by doing breathing exercise, and just a normal walk around the room, or maybe once the patient client goes home, it is more about like walking around the home. Ideally, the breast cancer surgery clients, they go home by the 5th day. So on an average basis, I'm telling, it is not always that it has been done with all the clients, but on average basis, the client goes home by the end of the 5th day. So we need to manage it and give them the home exercise program also, and we need to tell that how often she needs to come to the clinic. Ideally, with the mastectomy client, they should not lift more than 10 pounds for first 4 to 6 weeks, or if there has been done something like a reconstructive surgery of transverse or rectus abdominal, then they should not lift more than 5 pounds. This is very much important, because this can produce a lot of soreness or injury to the part of the procedure and the rehabilitation. Now see about a breathing exercise. The simple breathing exercise, it could be like diaphragmatic breathing, pursed lip breathing, thoracic expansion, and ACBT. So many times I got a question from so many physio that how you are making clients do thoracic expansion. So it is not always that you just do like this. It is not always required. There are so many other ways to do shoulder and thoracic expansion. The goal of thoracic expansion is to open your rib cage so that the lung will get the chance to fill the air inside. So any particular shoulder movement will also try to expand your rib cage, and that will give the leverage for the lungs to get expand fully. So many other exercises are there. Rebreathing exercise, and first thing is mental imaging technique of breathing. So many times, many clients, they breathe with the shoulder and the accessory muscles. So we need to re-educate the client and teach them the mental imaging technique for the breathing exercise, that how to use your diaphragm and your thoracic muscles or intercostal muscles while doing breathing. So teaching them diaphragmatic breathing, it is very much important. Again, for the relaxation, pursed lip breathing will help to relax and reduce anxiety in the clients. Thoracic expansion exercise will help to enhance the lung volumes. If the client is pre-stage of the surgery, if it is affected by COPD, then your ACBT and huffing would be better. Low pressure coughing is ideal. High pressure coughing is not advisable if the client is having the drain on. So try to understand that huffing techniques are well tolerated if the client is having drain after the surgery. Evidence also states that doing breathing exercises also reduce nausea, vomiting, and anxiety with the breast cancer clients. So this needs to be started with the first day after the surgery. Let's move forward with these are the basic signs that how we need to position the limb. So if you just hang the arm, which will put the gravity, it will swell more because the gravity, it is assisted position. So it will just try to pull the water content and the blood towards the hand. So just try to support the limb with pillows like this as shown. And for the hand movement, you can do something like a finger clenching or maybe ankle foot movement to prevent the complication and the contractures. Let's move about more specific. So there is something, if the client is having latissimus dorsi flap, as an example, you should avoid the stretching exercise for at least 2 weeks and strengthening exercise for 3 months after the surgery. So that's why we need to understand that what kind of management strategy has undergone and what are the surgery done. And that's why the teamwork and that's why the understanding of these processes is must for the rehabilitation professional. It's not that it's us that we need to get profound knowledge first to deliver the best to our team member also. So if the client is having let's dorsi flap, you need to avoid strengthening and stretching exercise for 2 weeks and 3 months on a consecutive basis. Then other surgery it called as a trap flap. So they just try to give a flap of transfer rectus abdominal muscle. There is more about like cosmetological purpose and more about if there is a large tissue which has been cancerous and which has been removed. So that particular part of structure is been transformed from the muscle to give the soft tissue filling, and that particular surgery called as a trap flap reconstruction. In like mastectomy, there is a basically many type of mastectomy has been introduced now. If you know about, there is a simple mastectomy or a total mastectomy where they remove the whole breast, the part of lymph node and the part of pectoralis major muscle. There is surgery called skin sparing mastectomy, then in which they just spare the skin of the breast and which can give a less scarring on the body. But if you have a larger structure involved, that particular surgery is not advisable. Other form of surgery called as a nipple sparing surgery. And that also they just spare the nipple and the around tissue and they do the surgery by removing the other part of the cancerous growth. But again, if you have a larger part of the cancerous growth, this particular surgery has not been advisable and there is a higher chance of getting nerve injury if you're doing this kind of surgery. Now just let's do about what are the exercise protocol. So let's start with 0 to 2 weeks. You need to start doing the exercises as shown over here with the neck exercises and with the arm movements. We will see per day how many exercise we need to do it. Each exercise we need to repeat it around 6 to 14 or 6 to 15 times each as per the place and client. There is a no thumb rule of repetitions. Try to understand that. Many researchers say that we're gonna do 30, 60, maybe like 90 times, but we need to understand the client. And as we know about the SPART principle, SPART principle is we need to be viable and standardized, but we also need to think about the individual person. If the individual person pre-fitness was not to do around 10 repetition, I cannot tell her to do around 20 after post-surgery first week. So we need to keep an accountable of that particular pre-surgery fitness also. So now these are the basic neck movement which every client can do it. And even if she has got drain or not drain, they can do it all these exercises. Now this is the very important chart of doing exercise. So these are basically exercise of 9 exercises, which day they can do it or which week they can do it. You can just try to implement as per your comfort level and the client motivation and her effort. You can try to do this exercise with the client for first 2 weeks. Now we just talk about more around 2 to 6 weeks. 2 to 6 weeks is more about shoulder flexibility and get back to the normal functional lifestyle. And so many times we need to manage with pain. Don't think that we're gonna give shockwave or ultrasound or other modalities for the pain. It has not been researched yet, and we cannot give any modalities to the same. So work with active therapies, as I told you, and try to start with low grade strengthening exercise by the second week onwards, and teach more about ADLs. So like many times in a developer, we do environmental assessment also. So we need to go to the houses of the client and we see that how the client lives, what is the social scenarios. If she needs to cook by herself, then we need to work accordingly. Then we need to try to teach her how to hold the utensil, how to wash the utensil with the same limitations. So all these things needs to be measured and monitored, and then we need to evaluate with the environmental assessment, and then we can try to formulate a strategy of rehabilitation. So with this stage, many of the times rehab professional, they go fast and they end up with the soreness or injury of the muscles. So be slow and watch out for the infection while this stage. So start with scar management. So you can also do by yourself, or you can teach the client of doing the circular manner or triangle scar management massage, or wound management can be better done with like wound management specialist if you have in your country. If not, we can learn and we can teach to the client that how it's to be done. It is more often to be done around 2 or 3 times a day for around 10 minutes. Please contact the doctor if you find any kind of infection or oozing around. Oozing is not so normal after around 4 to 6 weeks. So oozing around the site of surgery can be the sign of infection. So be in contact with the doctor and inform the doctor for the same. Let's see about the way of reducing lymphedema. So 2nd to 6th week is the main time frame where the lymphedema complication has been initiated. So we can try to reduce the chances of lymphedema by implementing this strategy, which is very much easy and which can be very much easily educated to the client. So you should not check the BP or maybe sugar on that particular side. Do not try to wear very tight clothes. You can careful while doing regular parlor works or manicure, waxing or beauty procedures. You cannot able to lift more than 6 kg of the weight, or do not do like so many exercises at once, and be careful about any kind of ulcers or the infection. So research also states that once you look after for this particular implication, chances of getting lymphedema after 6 months are reduced. So we also need to implicate this particular procedure, and we also need to educate our client for the same. Let's move around strength and resistance exercises. We can use different products while doing it. Either it could be around a water-filled water bottle, or maybe some kind of cold drinks bottle, or maybe dumbbells, or maybe stretching exercise with elastic bands, or so many other products which are available. You can do it. Try doing gently and keep your mind that what surgery procedure has been done on the client. So you can start with the half kg and then move maybe around 2 kg or like 3 kg by the end of 6 months. And most focus area are shoulder, elbow, upper back and chest. So I need to focus on that, and do not add any particular exercise for continuous way. So if I'm working on maybe shoulder, do not work on a everyday basis. Try to pacing yourself and try to differentiate the different type of exercise in a different days. So these are the basic exercise of like strengthening exercise which we need to work on. And for the how you can work with the elastic band also, you can start working like the same, and you can set this picture to the client so that the most of the client tell that we forget the exercises. So being an information designer and a writer, I do design so many other processes which gives an adherence to the clients to do the exercise. So once they have a clear, more focused and goal-oriented exercise chart, they adhere better. And visuals are always better to understand and better to remember other than the words. So even if you maybe after a few days, you may not remember my words, but you can easily read back the pictures or the slides very easily. So we need to produce more visuals to the client so that they can easily adhere to the exercise on a regular basis. Let's work on 6 to 12 weeks. So it is more about, again, scar management. Scar management, there is not much research has been done only on breast cancer, but in the past, we used to give like laser, a low frequency laser for around 4 minutes with 2 joules. So these are the frequencies of what we used to use. But when finding the paper, we haven't found much of the papers which is more evidence based. So I will not advise to give laser at this time. Aerobic exercise is mainly done on a SMART principle. Everybody know about this SMART principle, I guess. It is more about like standardization. It is more about viability, that it is viable or not. It is also about that if you are more into like achievable. So A for achievable, R for realistic, and T for timely. So this SMART principle, you need to work on a specific basis, on a measurable basis, on an achievable basis, on a realistic basis, and on a timely basis. So this SMART principle in every management strategy of a rehab is very much important. And I urge that you also follow the same principle, which could be better to get a good outcome from our clients. We also need to teach general conditioning and relaxation exercise to the client, and more of strengthening exercise and goal oriented, and return to the work planning. I get many clients that I need to go to play the golf. So can you see that how we gonna play the golf? So we need to work on the same particular goal oriented approach. Then there are many standardized early morning science scoring system charts are available. So this is SWOT chart are very much available in UK and in the European country, and we just need to fill this chart and see if the client is having more relevant to get the complication or not. So you can also just download from the internet, and you can just try to again see with your own clients and just try to adjust accordingly on an individual basis. So this is something like a strengthening exercise. Let's talk more about beauty principle. So this is something like a community based research paper which was published in 2014, and it was done in Canada. So it calls a breast cancer patient engaging in activity and undergoing treatment program. So this is a 12-week exercise program which has been community based, and they do the exercise on a community based on a fixed criteria, and they find it that this is very much better to address so many other non-possible things which is not accessible or maybe individual or maybe not safe. So it has been given a very good result, and I also urge that we in a developing world can also try to formulate something like a community health program of such into our country, and we try to compare the data and see that how we need to implicate the same or better strategies to give more sufficient rehab to our clients. So with this beauty program, their particular has been this criteria. So there has been doing mainly 3 things: aerobic, resistance, and flexibility part. So they have been divided into like 3 zones: red, yellow, and green. So as you see over here, all this thing has been principle by feet. It is like frequency, intensity, then your time and type, what we follow generally on an old style school. So it is based on FREET principle and SPART principle, both on a combined basis. So in a like aerobic basis, they start with doing around heart rate maximum by 40 to 60%. I hope everyone knows that how to calculate the heart rate maximum. So on a old school manner, we used to teach our clients to get heart rate maximum by 220 minus the age. So if we have a client of 40, 220 minus 40 is equal to 180. So that particular client has got a heart rate maximum of 180. So they can do the exercise or any activity which is making the client heart rate to 180. And also on a normal circumstances, even like WHO suggests to do at least around 45 minutes to 150 minutes of exercise weekly for heart rate maximum. So it is not about like running or jogging. Even if you are skipping, even if you are doing like a stair climbing, and that makes your heart rate max by 180, or no, as an individual, no heart rate max, it's okay. So in this scenario, you can see that how they are gonna transfer to the now FRIT principle on a maybe aerobic basis, on a resistance basis, and on a flexibility basis. So they have started with the 1 to 2 sets, then they have started with around 1 to 3 sets, and there is more than 3 sets. And like flexibility, they do on a regular basis. So like flexibility and aerobic, it is more complicated. It's not more complicated, but no resistance training on a daily basis. So you can try to implicate the same thing in your on setup also, and which you don't require a profound resources, because normally many times we have incapabilities to say that we don't have that machine and we don't have this instrument or that instrument. So implicating these do not require profound or unnecessary resources. So you can develop the such in your own setup also. Let's move towards, as you talk about like walking, cycling, swimming is always good. If it has not been complicated, anything on skin, no skin infection or something, they can do the swimming after around 6 to 8 weeks. Look after for fatigue and try to pace yourself. The sample exercise program will be around 5-minute large muscle group warm up with stretches. Then you move for the aerobic exercise for around 5 to 10 minutes, and then end up with 5-minute large muscle group exercises. Be careful when your goal to do the exercises are different with different kind of clients and different kind of management strategies. So do look after for that and try to not to make the patient carry weight more than 10 pounds if they have been done any reconstruction surgery from lats dors or maybe TRAM flap. So do keep it in mind and increase your 1 pound of lifting the weight every week up to around 4 weeks. So you need to increase the 1 pound weight every week for around 4 weeks, and then you can try to progress it on a better way. So this is 8-week multimodal physiotherapy program, which has been got published in 2018 also, and which has been involved maybe a sample size of rehab program with exercise with a week wise. But I personally prefer that it is not that we need to follow the same thing. You can try to modify according to your setup, according to the client, according to your geographical location. So it is not demand that you just follow this particular thing, as you cannot fill one size all to all the clients. So we cannot fit one particular research to all the clients. So you can just try to modify according to the availability of the resources, maybe your setup or maybe the client requirement, and how we need to modify it should be viable, and that's supposed to be research based. So you can just try to follow some of these principles, but you can modify in a different way. You need to consider some special things while implementing the rehab. So if a now person is having anemia, if the person has been given like radiation for a long time, you can see that that particular client must have been affected with bone marrow and anemia. So that particular client complain of fatigue too much or maybe generalized malaise. So you need to deal with the same and reduce your frequency and intensity and try to move further on a slow pace. Maybe if the client is on hormonal therapy or some kind of other therapy that may produce the immunity system down, so you cannot give high impact exercise to that particular kind. Many uh, peripheral neuropathies client, they also have the problem of getting burning and everything. So you also need to see that this particular exercise are not always good for that client. If there is a reconstruction done, as we talked about in many times before, you need to see that how to stretch, when to stretch and when not to stretch, and what are the weights that client can able to lift. And if there is a lymph node removal, try to watch out for the circumferences of lymph nodes and the lymphedema circumference of the arm. I hope I'm not going fast enough because we have too much to talk about. So I'm just going a bit faster. Let's talk about more of, there is just a brief about rehab. It's we can dig into one part in depth of all what we talked about, but this is in a brief that what we can do and how we need to do it. Let's talk more about lymphedema. So this is a 5-way what we can manage it. The most viable and evident research management strategy of lymphedema, it called as the CDT. It's a complex decongestive therapy, which includes bandaging, sleeving, compression machine, and then manual drainage, and again do the exercises. Breathing exercise also works better with lymphedema clients. So do also teach breathing exercise to your clients also. Now we see that management of lymphedema. It is mainly like non-surgical or surgical. Non-surgical mainly like physiotherapy and compression therapy, and surgical, it is not much famous in a developing world because it is more specialized and very expensive affair, and we don't have such expertise in our countries also. So that is your lymphovenous bypass and lymph node transfers, which is not readily done. I have never seen in Africa. I may be wrong, but in my experience, I have never experienced the same in African continent. It is more common in Europe and other developed countries where they do it for the cosmetological purpose, and the rehabilitation is much more profound on the same. Let's start with lymphedema management. So we as a physiotherapists, we are mainly dealing with manual drainage, your compression sleeve and compression devices and other exercises. So let's start with the compression sleeve. Let me tell you, most of the times when we are dealing with compression sleeves, just ask yourself clearly, do you know about what is the class of compression stockings? Of course, because we just see the prescription, or we must have seen the prescription from the doctor that they must have referred class to compression stockings, but we never thought about that. What is this class is all about? So compression stockings are a different types, and they have been divided in a different ways, but mainly it is day and night and graduating. Graduating means the pressure from your hand towards, from a distal to a proximal part has been graduating in a way the arterial and the venous pressures are compromised in our body. So it is more graduating. What compression stockings we are having in the market now, it is more graduating, and most of the stockings are made in Germany. What we get, I don't know in like Rwanda, but most of the part it is made in Germany, and the sleeves are different for the day and night. But even in my personal experience in Kenya, I never see medical professional prescribing day and night on a different basis. Why day and night? Because the arterial and the venous pressures are different in the day and different in the night. So the class of compression stockings are class 1, class 2, and class 3, which is on European standards. And generally, the normal arterial pressure is around 20 to 22 mmHg. So that's why to maintain the normal arteriovenous pressure, most of the times for the prevention of DVT and the prevention of clots, the doctor suggests class 2 type of stockings. So now you understand that why doctors or why we need to give class 2 type of stockings, that because that gives a normal arteriovenous pressure towards our arteriovenous system. Class 3 stockings had been given very rarely for lymphedema because that is also causes ulcers, because you cannot force the lymphatic system, because that can also reflux and cause the damage to the proximal part. So sometimes they give the compression stocking at night for some time, or maybe incidental basis, but most commonest is class 2 at night. If it has been day and night, both are different. So class 1 for night and class 2 for the day has been suggested for the lymphedema or the normal prevention of DVT. So this is very much important to understand about this compression sleeve. We can talk the whole day about this sleeve and the compression machine, because I teach different classes for the same. So we get more details in the other slides. Let's talk about what are the type of compression pumps. We must have seen the pumps or that the sleeves which has been wearing around the leg, and that has been given the pressure to reduce the swelling. So that called as a pneumatic compression pumps. It has been mainly like 3 types. It is program or non-program, or maybe calibrated or single or multi-chambers. So this has been mainly like classified. What we have, the commonest type of pump, it is like multi-chamber, non-programmable pumps, which is more commonly available over here. And like I've seen few of the company which is more profoundly famous in like Africa is Huntley. Huntley has got a good brand from Poland, and it has got a definitely have a good result also. So this is something called as a sleeve. What they wear the sleeve, the pressure what they impact inside the sleeve has been also different. So it can be a continuous, intermittent, or sequential, or gradient. So this is something like a single continuous pressure for the whole leg. Intermittent, it can off and on for around 20-30 seconds. Sequential is something like a different type of pressure on a different part of the way of the proximal to distal. It is more gradient. And sequential is first your distal will feel for 40, then your proximal, and then the proximal will feel for 40 of the same pressure. So this particular thing is very much important to understand when you are giving pneumatic compression machines to the client of lymphedema. A typical intermittent therapy would be given around 40 mm of Hg, holding for around 22 seconds, and deflate and hold for around 18 seconds. Twice a day for 1 hour each. So I generally tell my client to buy the machine because it is most convenient, and educate the client for the same, because giving the same amount, because this is something, lymphedema is something not been treated. It cannot be completely treated. It can be minimized, but it cannot be cured. So just have to understand its longevity, and patient cannot able to spend the same amount of money while giving the rehabilitation session. So it can take maybe around 10 to 50 or 60 or more sessions. So patient cannot spend the same time, and unless he or she can buy the machine, they can do it at their own comfort at home. And during this pandemic time, it has been more convenient for them to not to visit the hospital or the center. So you can also suggest your client to buy the instrument and educate them that how to do it and how to use the same, and you can monitor or guide the client accordingly. Only compression muscle doesn't work well. So decongestive lymphatic therapy always works better. Compression therapy with the bandages, even the bandages, we have a different type of bandages. We need to talk much more in the depth for the same, and we don't have much of time, but different type of bandaging are also available, and we need to have a profound bandaging type also. Having a knowledge of lymphatic drainage, you are being trained that how to do the bandaging, how to use a compression machine, how to manage the wound, and how to educate the client. So there is a different certification for this particular area of expertise. So being a cancer rehab professional, we have been trained to do the same on a regular basis, and we also try to implicate whenever it is needed. So in our, on a like general perform, I can say that manual lymph drainage is not massage. It is different from the massage, and manual lymphatic drainage expert have a knowledge of lymph node, lymphatic tissues, how to go, where to go, and where not to go, and what are the pressure needs to implement while on the skin or on the body. So it's not the normal massage. Try to differentiate the same. As I told that garment surgeries are different. We talk about compression machine. Physiotherapy, we need to teach the client about mobility exercises, flexibility exercises, bit of strengthening. We also need to talk about breathing exercise to the client, and we can talk more about that how we gonna also use different modalities if it is available. And we also need to teach for the weight control, skin care, and self-management also. So this is the general summary of lymphedema management, what we can implicate. Try to just figure out this. If you have, just try to avoid pressure on that side, avoid hot packs, ice pack or chest. Do not allow injection in the swallowing arm. Discuss proper exercise activities or therapies. Obesity may have negative effect of swelling. So you also need to watch for the weight, and any sign of infection, do contact to the doctor. I guess I'm not too fast. So now cancer is a word, not a sentence. I'm open for the questions. Please go ahead.
Thank you very much for the presentation. We appreciate the presentation, and participants did not type questions in the chat. I would like to ask if there is anyone with a question. You can raise your hand and we unmute you to ask your question. Thank you.
Okay, I guess no one has question, or my presentation was not good, or it was just not, or it was too fast.
Yeah, and I can imagine it's something new. And
yeah. No, this is my normal presentation generally, but it is more like visuals, and it is more about easy understanding of the clients. So yes.
There is a question here.
Yeah.
This gentleman is asking when physiotherapy is contraindicated to cancer patient.
Okay, so like physiotherapy as such has not been contraindicated fully, but few particular therapies are not being indicated. As an example, we have discussed that if like a patient is having a reconstructive surgery, exercise of a strengthening exercise are not being advisable. So it is now contraindicated. In terms of, if I give a like a different treatment options, so like pneumatic compression therapy has not been advisable if it like infected. On a normal circumstances, physiotherapy is advisable from the day one. We need to start doing ankle pumping and teaching about ambulation and about bed mobility. Physiotherapy is always been advisable in terms of goodness of the client. If it is something like a serious contact infections where you can spread the infections, or many of the times if doctors or the team of the doctors are not confident of the physio, and if they think that he or she may profoundly harm the patient, so they do not try to refer the client. Okay, that is what I feel over here. I generally see the client by around 10 days or maybe 12 days after the surgery, where already the shoulder has been more contracted. So there is no red flag for contraindication of physiotherapy in breast cancer. I can see a second question also over here about good contact materials. Yes, so we have a a specific gel available in the market with the low pH. What we call as a low pH is lesser than 5. But if you don't get that, you can generally use whichever oil you feel like, or whichever moisturizer cream it is available. But if you really want to use the profound material, you can use the low pH gel. It is not the ECG gel, or it is not the USG gel. It called as a low pH gel, which can be available in the market. If it is not available, use any particular moisturizing cream which is suitable for you and the client both.
All right, anyone else? All right. Okay.
If anyone likes to contact me, they can follow me on my social media. And yes, I do. I would like and urge to do. There is a one more last slide. Okay. First of all, thank you one of all to understand and bear my lecture, which was very fast. It is almost now 70 slides. So I guess no, giving this fire stand is not easy for me also, but I am very much thankful that who has been attended. And as we talk about, we need to follow this pure principle in our practice. I urge all the people to follow this pure principle, which is patient first, united approach, research-led, and expert care. This is in terms of every rehabilitation technique or rehabilitation management, what we are doing. Try to implicate the same thing in your rehabilitation treatment guide. This would be really helpful. And I urge all the people to use this in your practice. Once again, thank you all. And if anyone has a question or something, they can connect me or Jean, or maybe any of my social media or email.
Yeah, I thank you very much. I appreciate, and everybody appreciates your contribution. Everybody has followed, it looks like new, and in the practice, both medical doctors and therapists, they fear this kind of area. Yes. Sometimes when someone has cancer, they say, no, not physiotherapy, you're going to increase and you're going to so I think there is a need to do awareness, both for therapists themselves, medical doctors who do the transfer, like in Rwanda here, and especially for therapists, there is really a need for advocacy, but they really need to understand and know what to do. So I think if you agree, we could be able to organize more webinars like this.
Sure, of course. I generally urge to do a maybe on-site training also. Once this pandemic is over, I'm open for the on-site lectures, mainly for the prostate, ovarian, and the breast cancer. These are most three commonest cancer, which is more affected on a rehabilitation part. If we rehab better, they can get a better prognosis and they can better get a quality of life. So we can talk about more, and if it is available, we can do webinars, or by any chance, if it is a on-site like team of lectures or something, we can also do the same.
All right, fantastic. So there is where you say that chemotherapy-induced peripheral neuropathies.
Yeah.
It happens in between 30 to 40%.
Yes.
So I think this is a huge percentage where there is really a need to act.
Yes.
But in the case where there is still a problem, where people don't know and that they can really intervene, what do you think can be done?
Look, first of all, we as a rehab professional or the client, they don't know that what drug has been administered to them. I have asked the same question to most of my clients and they are not aware about. So now first thing is we need to get aware about that what are the drugs has been administered. In a developed world, there are a few drugs available which gives a lesser neuropathic complications, but that's a very expensive. So it has not been administered in a developing world easily. So the first option is awareness about the same. Second thing is we need to get a good screening process and good awareness factor as a client and a rehab that what drugs have been administered. We as a physio also need to know about in-depth knowledge about drugs and its pharmacological effect and the side effect. And fourthly, if there is a new drugs which are lesser chemotoxic drugs are available, we can also try to implicate or launch that particular drugs into African nations. Fifthly, we can always active persons have a better prevalence rate with chemotoxic neuropathies. So pre-fitness, if you are fit enough before the surgery, you get lesser sensory abnormalities. So we also need to learn more about rehabilitation also. So that's why we need to talk before the surgery or before the patient is going for the chemo or radio or the surgery. Other part, phantom limb pain. Educated clients are having more prevalence of phantom limb pain. Inversely, they have a lesser sensory limb problem, but they have a more phantom limb pain in compared to uneducated clients. So there is a two way of understanding the same.
All right.
And there is
Fantastic.
one more question that for the cancer patient, they say vigorous exercise are contraindicated because it has been increased cancer metastasis. This is not true. Exercise cannot metastasis the cancer. It has just myths and taboo. Don't believe in that. There is no research or there is no evidences follow the same. So it has not been stated in any research that it is impacted, exercise is impacted metastasis. So my answer is no.
Is another one.
The question is, mastectomy patient has edema of the whole upper limb. How long the edema resolve? What are the best treatment options for this patient? Okay. So we first need to diagnose that this edema, it is just because of gravity unassisted or it is lymphedema. If it is a lymphedema, you cannot cure lymphedema. If anyone is telling you that I am curing lymphedema, he is just bluffing around you. There is, even if you see lot many papers, you cannot cure lymphedema. You can minimize the effect of lymphedema. So the earliest sign is, what we have seen is, follow the instruction, do not take the BP on or do not give the injection, do not try to patient to hang her arm, okay, to the assisted position, try to mobilize the shoulder as early as possible. So preventable measures are better. Once you have the lymphedema, the best strategy is to start with, it called as a congestive, decongestive therapy. And if it is your compression machine is available, you can start with the same with manual drainage and other flexibility exercise, and also teach the breathing exercise. So there is not one particular strategy is based for the swelling. You need to follow the wholesome of the strategies.
Right, there is another one. No.
Yes.
Yeah, this is the one that is answered. Yes. All right. Yes. Fantastic. So I would like to thank you again for preparing the presentation and having this time for the presentation. And it's a great pleasure. It's a good introduction for us, and yeah, I'm sure it's going to help. This presentation has been recorded, and many people could be able to access it on our website or on Health-Edu website. And so I think you will be able to share the PowerPoint.
Yes.
All right.
But it's a huge file. I will just try to minimize to do something, because these are very high resolution images. So I will just make it larger because it's around 700 MBs. So I will just try to minimize it. Yes, because all these are actually no actual personalized, prepared, customized by me. So it's just high resolution images. So I will just try to reduce it, and I can do it better. In future, we can do it something on prostate cancer also.
All right, that's fantastic. So let me thank as well the participants. We had not many participants. We had Anatoly, Anita, Musi, Gladys. We had Jean-Paul Hakizimana, Jean-Paul Ndaisava, Marie-Paul, Solange, Michael Cavoy, Anisia, Demitil Sauda, Palma Wanjiku, Pravin Bavsar.
Yeah. Yes.
It looks like a name.
Yeah. Yeah.
Fantastic. We are grateful
fine.
for all the participants in this event, and we are looking forward for more events to come in the future. Thank you very much.
Fine. Have a nice time. Bye-bye. See you.